Hello everyone, this is Laura Dixon and I want to welcome you to today's program. We're talking today on part one of a four-part series on critical access hospitals, and in particular the conditions of participation. I'm going to be covering over these next four sessions the entire critical access hospital manual for CMS, that's the Centers for Medicare and Medicaid. Today we're going to be talking in general. We're going to be talking an introduction. How does the manual function? What's the general information on getting accredited or getting certified as a critical access hospital? Of course, I'll touch on some recent laws that occurred over the past couple years as they do affect critical access hospitals and really hospitals in general. And then I'm going to start bearing down on more of the clinical hospital-focused issues such as injection practices, advanced directives, and EMTALA. And of course, observation status, which happens to be somewhat big for some of our hospitals. Well, let's go ahead and get started. If you do participate, in other words, you get funding from CMS, you have to meet all of the conditions of participation. And that's for all patients, not just Medicare and Medicaid, every patient. And in fact, there are some that are very specific for Medicare and Medicaid patients. Now, these happen to be the problematic areas for critical access hospitals orders. Verbal orders in particular, and we're going to talk about that over these next four sessions. Hand hygiene still remains large, and that really focuses in not on just safe medication, but infection prevention and control. Well, let's go and start with an introduction to what we're covering over these next four sessions. So how did this all start? Well, there were two major rules. They came out on the same day. Hospital Improvement Rule, there's a whole big fancy long name for it called transparency, and the discharge planning. Now, the final regulations, they were published in September and went into effect 60 days later in November. It talked about emergency preparedness, swing bed requirements, discharge planning standards, QAPI, infection control, now called infection prevention and control, and the start of the Antibiotic Stewardship program. In 2020, they deleted multiple tag numbers for critical access hospitals, and they renumbered them all, as a matter of fact. There's no advance notice of any surveys anymore. Well, now I'm going to go through a couple memos. I want to start with texting. CMS actually put out a memo on texting between healthcare professionals. There was also one they put out on safe injection practices. Now, they did put out ISMP, Institute of Safe Medication Practices. Wonderful resource. If you're in medication safety, if you're in pharmacy, of course, you should be well aware of this. And their guidelines are pretty basic. Well, let's switch over to the worksheets because I did talk about those briefly. So I'm going to talk just briefly, right now on swing beds. All right, let's move to emergency services. You have to have a qualified director, and that's your medical staff determines what their qualifications are, what's the criteria. As far as EMTALA, this is tag 882. You have to have 24-hour emergency services available. If you need them, equipment, airways, of course, ambu bag. Oxygen, that's an equipment. They do have a separate tag for blood and blood products. You just have to store it and must be under the control and supervision of somebody who's qualified. Usually that's a pathologist. So let's now move on to just location and status. No more than 25 inpatient beds, and as I mentioned, that does not include ED carts or beds, observation beds, sleep study beds, that whole laundry list. Observation services. That's a very well-defined set of specific clinically appropriate services. What do you need in order for observation status? Hospice, that can be a dedicated bed. So again, thank you everyone for attending. I do want to just flip through a few of the resources that we have available here in the appendix. Hopefully I can get the slide here to advance. There we go. These are the web links, some general resources. Some of these may look familiar to you. I did include them in the actual body of the presentation. FAQs, the Rural Health Information Hub, wonderful resource. I would definitely tap into that. Also, your state flex profiles, the updated site for critical access hospitals. I did include some of the memos just as an FYI. If you wanted to go back, there is through the University of North Dakota. I would check to them. They have a wonderful checklist for critical access hospitals to get you ready for potential survey. Thank you very much. I will go ahead and close this out. Again, reach out if you have any questions. CMS is always a wonderful resource. That way you have it right from them. And definitely keep a copy of whatever email response they do send you. So thank you for attending. This concludes part one of our four-part series. Thank you.